So the Molecular Tumor Board, at the initial part of it, we talked about the role of molecular diagnostics in the treatment of breast cancer, and we talked about the role that a molecular tumor board can play in assisting oncologists in order to interpret these complicated reports. There's some nice data that was shown about the comfort level of oncologists for interpreting the reports as the reports get increasingly complex. So going from single gene mutations to multi-gene panels to even whole exome or whole genome sequencing, the confidence level of oncologists in interpreting the results of those reports goes down pretty significantly, and that's where the role of the molecular tumor board can come in. So a good molecular tumor board will have medical oncologists, will have molecular pathologists, will have potentially scientists who are investigating these particular mechanisms, and then also patient advocates. So that's something that was new for me to hear about, the importance of patient advocates on the tumor board, but I think that is very important. And then after we had reviewed that overview, we went through a few different cases with some interesting and I think very relevant and informative questions. So there was a case looking at a patient with hormone receptor positive, HER2 negative breast cancer who had both an ESR1 mutation and a PIK3CA mutation. So how do you interpret those kinds of results, and how do you choose what treatment strategy you would like? We talked about the role of TMB high in breast cancer and whether or not we should use immunotherapy in that role. And then we did talk also about HRD deficiency outside of the context of the standard germline BRCA1, BRCA2 mutations, but thinking about patients who have somatic BRCA1 or BRCA2 mutations or germline PALB2 and the use of PARP inhibitors in those settings.